I'm Anea.
I'm Ashwini. So we're both F1 doctors, both ex-Georges, GEP students as well. So we've been doing this crash course series for about 2 years now, and we've kind of made it official this year with a Facebook page and everything. So we just kind of do end of module like revision sessions, and we do 2 SBA sessions just before each exam that you have. So one in February, and the other one's in like roughly June time. But we'll be obviously updating you with the dates for those as we go along. Anything you want to add?
I'm at Georges. I'm an F1 at Georges. So if any of you guys, I don't know, if you need any help with anything, I am around, and I'll put my email in the chat later. And if you have any questions or whatever, I'm more than happy for you guys to get in touch with me, or we can go for a coffee or anything. So that's the only other thing I had to add.
Yeah, you haven't advantage here. So yeah, honestly, just abuse her as much as you can for the next year.
I won't say that. But yeah, I'm happy to help if I can. So yeah, cool. That's it really.
Okay, we kind of covered this, but I just kind of made a little slide of tips of getting through the first module and just the rest of GEP. So just kind of make sure you focus on the key concepts, and we've both tried to highlight what these are in each of the topics. And there's a few things which we haven't covered, which we've listed at the bottom, but it's usually like minor things which you can kind of cover on your own. If you do have questions, obviously email us. You can send us a message on, I think it's Facebook as well. And we have an Instagram account as well, which Nisha, someone else who's part of our little organisation committee thingy, also set up. So there's a few ways to contact us, and I've just kind of plastered my email on most of the slides, the introduction slides as well. So feel free to email us as well.
If you have any questions as well, it's quite tricky online, but if you want to unmute, I'm happy for mine for you.
Yeah, same.
Just unmute if you have questions, or we'll try and keep an eye on the chat as well, but I don't know how easy that is.
Yeah, I mean, my one keeps popping up on my phone, so.
But we'll try and keep an eye on both, but we're not ignoring you if we don't see it in the chat. It's just that we haven't seen it. So yeah, please unmute if you want to.
Okay, someone unmuted themselves, that's fine. So yeah, just kind of remember, you're starting from scratch. Don't worry about what background you come from. It's almost like you've just come out of high school and just restarting, but just going at twice the speed than the undergrads, really. But you're also learning less content than them, because you'll realise once you qualify, a lot of the stuff you learn in the preclinical years as undergrad is not very useful, because you need the clinical stuff which you're focusing on right now. So next year you'll find what you've done is a lot more helpful in terms of approaching a patient than what the undergrads have learned. And just kind of going back to the spiral learning, everything you've kind of come across this module, you'll come across in the next few modules as well, and literally throughout medical school. So don't worry about not getting it the first time. For me, it definitely took me a couple of times to get my head around things. So I'd memorize things, but I wouldn't truly understand it until later on. So don't worry too much. I think someone was typing. Oh no, someone just joined. That's fine. Okay, so anything else you want to add before?
No, not really.
Yeah,
cool. We're going to try and, just for today, I think each of us have got, so Ash is doing the first 2 weeks, and then I'm doing the last week. We try and keep them to like just under half an hour, like between 20 minutes and half an hour each case.
Yeah.
So today it should be under an hour and a half.
Yeah. We'll get there. Cool. So I do have my phone here with the chat open. So there's any questions, you can put that in there, or you can unmute yourself, or for the SBAs as well, just put it in the chat, because we haven't quite figured out how to get the polls up on Teams. Cool. Okay, so the first bit was introduction to the respiratory system. So your case was carbon monoxide poisoning. So I'm just going to kind of go through the basics here, and then we'll kind of just go through the basics of the case itself at the end. So this is just a quick kind of whistle-stop tour of the anatomy. So I'm not going to go into too much detail here, but I'll put a diagram here, and I'll be sharing the slides with you guys later on as well. The key points are gas exchange occurs at the level of the alveoli, and it occurs along a concentration gradient for oxygen and carbon dioxide. And I'll go through what a concentration gradient is and how this all occurs as I go through. So just to kick off with hopefully what I think is a simple question, if you can just put your answers in the chat for this. So which gas is the most abundant in the air? We've got one person answering so far. Do you mind doing like a 20-second timer? Maybe, yeah. Not for this one, next one. Cool. Cool. Okay, so yeah, most people have put B, which is correct. So yeah. So in terms of composition of room air itself, 78% of it is nitrogen, 21% is oxygen, and then you've got 1% which is other gases, which includes things like carbon dioxide, sulfur dioxide, argon, and all those kind of things. So, as I mentioned, oxygen and carbon dioxide in the alveoli itself moves along a concentration gradient. So it's from a low concentration where there's less, from a high concentration where there's more molecules of a gas to an area where there's less molecules of the gas. So in deoxygenated blood, so blood coming back from the body, there's not that much oxygen in there, whereas there's more oxygen in the alveoli itself. So you'll have the oxygen diffusing into the bloodstream. And at this point here, you'll see that there's a lot of carbon dioxide in the bloodstream, but less in the alveoli. So that diffuses out, and that's how gas exchange occurs. And the key thing, which I think you've come across an ABG for the patient in your case, and it's based on partial pressures of gases in the blood itself. So the partial pressure is based on individual gases in the blood, and together they make up the total pressure. And this pressure kind of also determines this diffusion gradient as well. And in terms of transport of carbon dioxide, it's usually as bicarb, but some of it is dissolved in the plasma too, or bound to hemoglobin, but that's a small percentage. And this equation here, you'll revisit later on, so I'm not going to go into too much detail right now. I just want you to get the key concepts first. Okay, so cellular respiration is how energy is made, and your energy currency is ATP. And you have about 32 roughly produced in the electron transport chain, and the remaining comes from things like glycolysis and part of the Krebs cycle. So the other thing to kind of note here, which isn't in the diagram, is if you don't have enough oxygen, which is crucial for the electron transport chain, you end up going down anaerobic respiration, which you end up producing lactic acid, which is your lactate that you find in your blood samples, and also leads to acidosis, which you see in the ABG. And things which affect this is carbon monoxide, as in the case, and other toxins which you'll come across later on, which can also interfere with the process. So, which conditions will lead to a right shift in oxygen hemoglobin dissociation curve? So, what makes hemoglobin have less affinity for oxygen? You just pop your answers in the chat. Thank you. No ring. Okay. Do we need to stare at it? Got one person answering so far. Maybe double it. We'll give you another 20 seconds to get more people to answer. Getting loads of A's. Guys, You're on fire here. Well done. So it is A. So high CO2, low pH, and high temperature can decrease the affinity for oxygen. So over to the next slide. So hemoglobin itself, and A is going to go over this a bit later in more detail as well. It's made up of 2 alpha protein and 2 beta particles and 4 heme groups, which make up the whole hemoglobin molecule. And each heme can bind 1 oxygen molecule. So with 4 heme groups in there, it means a total of 4 oxygens can bind to it. So this curve here is based on kind of 1 oxygen kind of binding. So if you think about it as kind of like an empty bag and trying to fit the first thing in, it takes a lot of effort, which is why there's low affinity. And then as you have more oxygens binding to it, the affinity goes up. So for the second and third one, it binds quite easily. And then for the last one, it takes a bit of effort as well, just to kind of squeeze it in almost. Now, in conditions where there's lower carbon dioxide, where there's higher amount of oxygen bound as well, which is kind of having your first and second oxygen bound to the hemoglobin. And if there's lower temperatures, hemoglobin has a higher affinity for oxygen, so things bind easily. If, for example, the pH becomes lower, so more acidotic, if the temperature increases, so say the patient has a fever, and if they're retaining carbon dioxide as well, then your affinity for oxygen becomes lower and it won't bind as easily. And I think I mentioned this later on, but when carbon monoxide, for example, binds to it, it affects it binds a lot more strongly than oxygen for one, and it also affects the kind of conformational change that happens when things bind to the hemoglobin, which makes it a lot harder for it to unbind from it. Okay, so literally just covered this without going on to the slide. So carbon monoxide binds irreversibly, almost irreversibly, and it just kind of takes up the space, so oxygen can't actually bind to it, and oxygen's not able to kick it out, which is what the problem here is. And this means that you don't have oxygen being transported around because only so much of it can be dissolved in the plasma, because the majority of it is bound to hemoglobin to be transported. Yes, yeah. And then other actions is it goes and kind of affects your electron transport chain and binds there, so oxygen can't bind to that. So the main process in the electron transport chain is oxidative phosphorylation, where these molecules, NADH and FADH2, these become oxidated with the oxygen, and that's what kind of pumps everything through to get your ATP molecules getting pumped out. If carbon monoxide gets in the way, then oxygen can't do its job there, and the whole transport chain just gets backed up and you don't get enough ATP, and that's when you go down the anaerobic respiration path. I'm just going to check if there's any questions. Can't see anything. So we can carry on. So just going through an ABG for carbon monoxide poisoning. So as I mentioned, you get you go down the kind of anaerobic respiration pathway, get lactic acid being produced. So in the ABG that you'd be a lot more acidotic. You're also breathing off a lot of the carbon dioxide, because carbon dioxide as a gas is acidotic. So you try and get rid of that. And then you've got your bicarb here, which is making it more alkali and buffers the acid. So that becomes less as well, just to help kind of make it less acidic. So these are the changes that you normally get. I wouldn't worry about being able to read an ABG right now, because in the next module, you'll be looking at it in a lot more detail. The other things just to note with carbon monoxide poisoning is you've got your carboxyhemoglobin levels, which are quite high. And in normal people, it's usually below like 1%. if you live in London, it's a bit higher than that. And if you're a smoker, it's between like 2 and 9%. And then you get your oxyhemoglobin, which should be between 94 to 100%. So if you guys have done the vital signs clinical skills, you'll know that your oxygen stats should be between 94 to 100, which kind of matches this in your bloods. And it's a lot lower if you've got carbon monoxide poisoning. And the other things in terms of just clinical presentation, you would want to kind of consider their consciousness level. So AVPU is an acronym that we use. So you'd start off with looking at the patient and seeing if they're alert. If they're not, then if they're going to respond to your voice, then the next step is seeing if they respond to pain. So usually just kind of pinching at their shoulders, rubbing the sternum, and see if they can if you can rouse them. And then last U is just unresponsive. Nothing's going to get them awake. Other things to look at is the blood pressure, heart rate, the respiratory rate, which is easily missed. So it's always important to make sure you do that. Easy way to do that is, I think, when you're feeling for their pulse, just kind of carry on. So I measure the pulse for 30 seconds, but I set the timer for a minute, and the other 30 seconds I just measure the respiratory rate. And the patient usually doesn't realise you're measuring their respiratory rate, they just think you're taking your pulse. And so they're not altering their breathing because they're focusing on breathing because they know you're checking it. Other things to always check for patients is checking for pain, checking for any kind of medications or any substances which can affect them. So things like cocaine and things like that. And then smoking and alcohol is also an important thing that you want to consider. I think that's the first one. Does anyone have any questions? Okay. So the only thing I missed out here is the detailed structure of the airway. I've put, so that's something that you come across again in your next module. It's something you kind of just end up having to rote learn instead of having to understand concepts. So I didn't really want to go over that. But if you do have any questions, feel free to contact me, or just ask at the end as well if you want to. So I'm going to move on to the second presentation if no one's got any questions. So, introduction to fluid balance. So this is your diarrhea case. Starting off with an SBA. So you're out for drinks with your friend. Your mind wanders off thinking about fluid balance in the body, as it does. Roughly what percentage of the body is made up of water? If you can put your options in the chat, please. I'm getting loads of D's. I'll just give you a little bit more time if anyone comes through. Okay, so all of you put down D, which is right. So next question. You continue drifting off in your thoughts about fluid balance. You wonder, on average, what percentage of fluid output is due to metabolism? Okay. Okay, so we're getting a bit of a mix here now. Just give it a good guess. It doesn't really matter if you get it right or wrong. We're going to go over this anyway. Okay. All right, so we've got some A's and B's and got a D as well. So the answer is B, 10%. So just going to go through some key facts here. So I'll get back to this question in a little bit. So our body is made up of roughly 60% of fluids. So males at 60 and females is about 55%, and the rest of it's solid. And of that 60-ish%, about a third of it is your extracellular fluid, and then 2/3 of it is your intracellular fluid. So intracellular fluids is the fluid that's within the cell, so usually your cell cytoplasm. So technically our cells are like a little sack of water, if you think about it. And then your extracellular fluid is all the kind of fluid around your cells, just kind of in that space between all your tissue. And 20% of that is the fluid that runs through your blood. And then roughly we have a total kind of volume of 40 litres, roughly, depending on each individual. On average, we look at a 70 kilo male is what this is all based on. So about 40 litres in the body, of which is your 60%. About 25 of that is your intracellular fluid, and then you've got a total of 15 litres, which is your extracellular fluid. And of that, you've got about 3 litres, which is in your plasma in the blood. And this is what kind of dictates your kind of vital signs, so your blood pressure, and then that kind of escalates to your heart rate and respiratory and things like that. In terms of fluid input and output, about 10% of this is your metabolism, so respiration and all your other metabolic processes produces water. So that's 10%. 30% of it comes from food, and 60%, which is a big bulk of it, comes from just whatever you drink in the day, so your water, your juices, and all that kind of stuff. In terms of output, majority of it is your urine. Then you also have insensible losses, so things like sweating, the water vapor that you breathe out of your lungs, which makes up quite a big chunk as well. And then you've got your feces, which has about 4% in there, unless you have diarrhea, of course. And this is just an average kind of intake and output. Next question. You're now a medical student on placement. It's been a slow day for you, so your F1 decides to quiz you to entertain themselves. He asks you which ion is the most prevalent in extracellular. So if you put your answers in, do you mind doing it for me, please? Thank you. Honestly, guys, it doesn't matter if you get it right or wrong, just keep guessing. Oh, hold on. This suddenly just started flooding in with answers now. Okay, so most of you have put down A, which is correct. Well done. So, in extracellular fluid, majority of the ions are sodium ions. In intracellular fluids, it's your potassium ions. The other one that you want to think about is your fluoride ions, which is extracellular as well, and that makes up majority of your anions, so your negative ions as well. And it's really important to make sure you have a balanced charges on the inside and outside as well, just to make sure everything's running smoothly. And this is kind of the key bits that you need to know, is what I've highlighted on the side here. There are all these other ions, but it's not relevant for you right now. It's just to kind of give you a picture of what else is going on, if you're interested. So just going to go through how blood pressure is affected by all this. So your osmotic pressure and your hydrostatic pressures kind of help dictate blood pressure. So osmotic pressure is the pressure on the solution to prevent the fluid from moving out. So that's dictated by the solute particles itself. So the more, let's say, for example, the more sugar there is in a solution, the more likely it is to keep the water in. Then hydrostatic pressure is the pressure the fluid itself exerts on the surface. So blood, the more volume of blood there is in your blood vessels, the more pressure it's going to exert on the blood vessel surface itself, and that helps to kind of increase the blood pressure. If there's less, so there's volume loss in the bloodstream itself, then there's less pressure, so your blood pressure goes down. So yeah, and this is kind of key in allowing fluids to also move between intracellular and extracellular compartments. So if let's say the extracellular compartment becomes a lot more concentrated because you're losing fluids, then water starts moving outside of the cells, and your cells start shriveling up. And then osmolality is something that you'll come across in investigations, and that's usually the amount of this actual solute itself in the solution. So this is just kind of a bit more of a diagrammatic representation of what's going on. So let's say this is a cell and this is the extracellular fluid here. This is a lot more concentrated in terms of the solute, so the pink dots. That means the water concentration effectively is lower. So this water, there's a higher water concentration on this side because there's less solutes. So that's moving to the other side where there's less water. So this is kind of effectively less water, and it's helping dilute this, so the concentration is equal on both sides. Because there's less of these solute particles in here, then the osmotic pressure is lower, so it's not holding that water in that compartment, which is allowing it to all leak out. So the other things that you'll come across is types of solutions. So hypertonic means there's a lot of solute. So I always remember it as tonic means solute. So if there's a lot more sugar and salts outside the cells, then I mentioned it shrivels up. On the other hand, if it's hypotonic, so there's less solutes like sugars and salts and things like that on the outside, then that means it's not holding the water in the extracellular compartment, and it starts flooding into the cells, and eventually the cells just get too full up and it can burst. And isotonic is when it's balanced on either side, so there's just equal amount of fluid moving in and out just simultaneously. So there's a couple of ways in which things move in and out of cells. So diffusion through these ion channels and passive diffusion just across the membrane is both of these are just passive, and it just happens across concentration gradients. Then you've got facilitated diffusion. So glucose moves in, for example, through a facilitated carrier protein. And then you've got active transport through these ATP pumps. So active transport requires ATP energy to get the pump to work and move the ions in and out. And this goes against, the active transport goes against the concentration gradient, whereas all of this goes with the concentration. So it goes from a high concentration to a low concentration, whereas this goes the opposite way. Okay, I'm just going to check if there's any questions. Okay. So kind of gone over this already. I've just kind of covered how these things can affect blood pressure. So let's say this bit here is your blood vessel here, and this is your extracellular, so your tissue, the fluid in the tissue. And so you've got all your blood cells in there, and you've got kind of equal movement because the osmotic pressure here is less than that. So there's no less, because of the difference in the osmotic pressure, despite the amount of solute, there's no net movement. Whereas if you got sort of if you've got the same amount of fluid on both sides and you've got different amounts of solute molecules, then you'll get a net movement towards the side with more solutes. Okay, so just going on to the next question, so we can get time ready. So a 22-year-old female comes into hospital following multiple episodes of watery diarrhea after eating takeout from a local restaurant. She has signs and symptoms indicating dehydration. What do you think is the mechanism underlying the dehydration? So we can get you guys to put options in the chat. Okay. I can only see one so far. Don't know if it's my phone being a bit funny. Oh, okay. Yeah, it was just my phone being funny. Yep, so we got a bit of a mix of answers here by the looks of it. We've got some A's, B, a couple D's coming through. Okay, so the answer is none of the above. So D, well done guys. Okay, so just going to go through what happens. So with food poisoning, which can lead to watery diarrhea, certain bacteria just kind of alter the way the ion channels behave. So, for example, they can upregulate the ion channels, which leads to kind of secretory diarrhea, so your watery diarrhea. So your ions are being secreted from the cells into the intestinal lumen. So it becomes a bit more concentrated in there. And because that's a lot more concentrated, it starts drawing more fluid into the lumen as well, which makes your stools a lot more watery, which leads to watery diarrhea. But then you need to think about where this fluid is coming from. So your first point is your plasma. So your plasma volume starts decreasing. That means everything in the plasma itself becomes a bit more concentrated. Then as that becomes more concentrated, then the fluid in the intracellular compartment start to shift out as well, because it's drawing out because of the osmotic pressure and it's being drawn out of the cells. And then as the cells start, it becomes a lot more shriveled up, and without any fluid replacement, the cells start dysfunctioning, and then it can eventually lead to dehydration, and if it's still not sorted out, then death. So I put this image in here because I thought it was quite nice, just kind of seeing what's going on. So here you've got this tap is basically just representing these ions being kind of pumped out, and with that the water is just following it. Because that's emptying out, this needs to fill up. So the tap in your cells open up and the fluid starts coming out of there. So this is just a set of OBS and bloods that you get in the patient. So I think you've got something similar for the patient in the case as well. So the blood pressure is quite low, and then you got your postural hypertension here. That should be hypotension. So you got your postural drop here when they're standing up, where their blood pressure just plummets even more because they don't have enough fluid in their blood plasma. So the hydrostatic pressure on the vessels is less, which makes the blood pressure much lower. Because it's a lot more concentrated, then your sodium levels and your urea levels start going up, because it's just not because there's something going on, but it's just because it's just becoming a lot more concentrated in the blood. And then your pulse rate starts going up as well, because you're trying to compensate for the low blood pressure and trying to make sure your whole body is still perfused. So your heart works a lot faster in that case. So that's the end of that. Does anyone have any questions at all? So things I didn't cover is the structure of the kidney and the nephron, which you will cover in a couple modules time. And chemical transmission and drug action, it's little things that you'll start picking up in the modules as you go along when you cover some of the drugs. So I didn't really spend too much time going over that. But again, if you have any questions at all, please do email us. We're happy to answer. So I think I'm just going to hand over to Anaya now.
Can I steal your phone to look at the chat?
Yeah.
So I'm going to be going through your last week of the foundation module, which was on anemias and sickle cell. So first thing to know about is what is anemia. So anemia is a condition in which the hemoglobin concentration is lower than normal. Women tend to have slightly lower levels of hemoglobin anyway. So in women it's less than 120, and in men it's less than 140 grams per litre. There are a couple of different signs and symptoms of anemia that you need to know about. So if someone's particularly pale, if they get fatigued easily, if they feel breathless, have palpitations. And the last three ones that they kind of come up quite a lot in clin skills, and I never actually used to know what they looked like, so I've put some pictures in. So koilonychia is when you get this weird spooning of your nails, like in the top picture. Angular stomatitis is where you get this like cracking of the skin at the corner of your mouth. And glossitis is where you kind of lose the normal texture of your tongue. So instead of having these normal, what are they called, the bumps on your tongue? Taste buds. Yeah. Instead of having them, they just look, your tongue just looks kind of smooth and shiny. That's what glossitis looks like. So when you're thinking about anemia, there are kind of a couple of different ways of looking at it. So either you look at kind of what's caused the anemia in terms of the pathophysiology. So you could have that the body's failing to produce enough hemoglobin, and that can be due to either B12, folate, or iron deficiency. Iron deficiency is kind of the most common cause of anemia overall. You can have EPO deficiency. So in chronic kidney disease, your kidneys usually make a hormone called EPO, or erythropoietin, which helps stimulate the bone marrow to make blood. So if that's low, then you won't be producing much blood, or your bone marrow, where your blood's made, can just be failing. There's also failure of appropriate utilization. So that's anemia of chronic disease, which is where your body's in this inflammatory state. And even if you have all the components you need to make hemoglobin, your body just doesn't really kind of process it properly. Or you can just be simply losing lots of blood. So if you have increased destruction or loss, so if you've got kind of heavy periods and GI bleeds, kind of really common things to look out for. Trauma, obviously, but I feel like that's one that you don't really have to think about, because it will be quite obvious if someone's, you know, bleeding massively and you can see it. But if they've got heavy periods or GI bleeds, they can kind of, you need to make sure that you actually ask the questions about them. And then the other reason for having an increased destruction or loss is hemolysis. So that's kind of more what we're going to talk about today with sickle cell and thalassemia. So that's the way of looking at it in terms of pathophysiology. The other way that's talked about for classifying anemia is looking at the actual size of the red blood cells. So you can have microcytic anemias, which is where the size of the cells is kind of less than 80. And that's what you get in iron deficiency anemia, thalassemia, and the late stages of anemia of chronic disease. You can have a normocytic anemia, where the cells they look normal in size, early in anemia of chronic disease, that's what you'll see. If your bone marrow is kind of failing, you get aplasia, where it's just not making enough, but the cells that it is making look normal. Or chronic renal failure, which goes back to EPO, and if you're just not producing enough EPO, then your bone marrow is not being stimulated enough, but the cells that it does make look normal. And then when you move on to macrocytic anemia, where the MCV is above 100, then there's a nice mnemonic, which is red blood cells, which stands for folate deficiency, alcohol, thyroid, reticulocytosis, which is where you have lots of immature red blood cells called reticulocytes in the blood, and they tend to be bigger than normal. B12 deficiency, and there are some cytotoxic drugs that cause a macrocytic anemia. So that's things like phenytoin, methotrexate, azathioprine, can't think of any more. But yeah, there are some drugs that you should probably be aware of that cause macrocytic anemia. So first question, you are on placement in GP when a 30-year-old lady comes into the surgery complaining of feeling tired all the time and getting breathless when walking up the stairs. On further questioning, she tells you she has been having particularly heavy and long periods recently. What would you expect to see on her blood tests? So if you could just type in the chat, that would be great. Yeah, maybe. By the time I get there, time will be up. But
Me with doubling kindness.
True. This is kind of a tricky, I get this one probably takes a bit more time to figure out. So.
Last time everything just came in masses up.
Really?
Yeah. It's my. Yeah.
Maybe it's the same. Oh well, give it till the timer goes off and then we'll just talk through it. Oh, okay. So we had a bit of a spread of answers, which I think, yeah, that's kind of expected with this one. But the answer is actually C. So what I'm getting at in this question is if someone's coming in, the most common cause of anemia is usually iron deficiency anemia. And especially in this question, I've hinted at it by saying that she's been having these long, heavy periods. So if someone's losing blood, either from a GI bleed or heavy periods or any other reason, they're usually going to end up with an iron deficiency anemia. And in iron deficiency anemia, it causes a microcytic anemia. So the MCV is low, so it's less than 100, sorry. And you also get low ferritin because ferritin is how iron is stored. And if you've got low iron, you're also going to have low stores of iron. And then you get a high total iron binding capacity, which is kind of a measure of transferrin, which is a protein that helps to move the iron about to where it needs to be. So that's high because if you've got an iron deficiency anemia, you want to try and utilize all the iron that you have, make sure that you're using it really well because you don't have much of it. So your transport of it is going to be better than it usually would be. So I hope that makes sense, but if it doesn't, then let me know. Oh, there's way more answers.
Yeah, I know.
Okay, quite a few of you did say C actually, but yeah, it's a bit of a mixture. It was a tough question. So blood components is the next thing I wanted to talk about. So your blood's made up of kind of these three different parts. So you've got your plasma, which makes up about 55% of your blood. And that's where you've got your water, your ions, proteins, gases, wastes and nutrients. So that makes up the majority of your blood. Then you've got a very small part, so 1%, which is made up of your white blood cells and your platelets. I've listed kind of all the names of them here, but you do come back to it a bit later. I wouldn't worry about it for this week. I think you come back to it a lot more in life, what's it called? The infection one, life protection?
Yeah, life
Life protection.
Yeah.
Yeah, life protection. When you learn about all the infections and things, you do a lot on white blood cells. So I'd kind of worry more about it then. And then 44% is your red blood cells, which is what this week's focusing on. So Ash kind of talked about hemoglobin earlier, but we'll go through it again. So each red blood cell has roughly 250 million hemoglobin molecules in it, which is a mistake I used to make. I always used to imagine one red blood cell with one hemoglobin molecule, but they're actually, 250 million. And then within each of those hemoglobin molecules, you have 4 heme groups, and that's where your oxygen binds. So your oxygen binds to the ion in the middle of the heme group. And so that means, if you do some maths, it means that each red blood cell can carry up to 1 billion oxygen molecules. And the hemoglobin, your normal hemoglobin, a normal adult hemoglobin, is made up of 2 alpha units and 2 beta units. And that's what makes up kind of about 95 to 98% of the hemoglobin in adults. But there are a couple more that just to be aware of. So in kind of fetal hemoglobin, so in fetuses, they have kind of 2 alpha and then 2 gamma chains. So just a slightly different subunit. And that's actually present, even though it's called fetal hemoglobin, it is present in adults, but in just very small amounts. So it's kind of 2 to 4% in adults. And there's this other very minor one called HbA2, which is present in adults in very small amounts. And that's again got 2 alpha chains and then 2 delta chains. So it's just a slightly different sequence of the amino acids in the chains. So what type of protein structure is hemoglobin? So primary, secondary, tertiary, quaternary, or quinary? Quite a quick one, this one. Yeah, getting lots of answers in. All right, so like everyone who's written in has said D, so quaternary, which is the right answer. So it's just a very quick thing to recap. So primary protein structures is just a sequence of amino acids, so just a chain. In the secondary structure, it's when that chain either becomes a sheet or a helix. And then the tertiary structure is kind of where, when you take a step back and look at that whole chain and what it looks like. So like one of the subunits in hemoglobin. And then the quaternary structure is when you have multiple subunits put together. So like in hemoglobin, you've got those 2 alpha chains and the 2 beta chains all put together into one bigger structure. So we're going to move on now and talk a bit about sickle cell. So sickle cell occurs when you have a point mutation on the beta globin gene, which is located on chromosome 11. And basically what that results in is usually in your beta globin, you have a glutamic acid, but when you have this point mutation, that glutamic acid gets swapped for a valine. And that's not really a problem when the hemoglobin is oxygenated, but when the hemoglobin becomes deoxygenated, the shape of that chain actually changes a little bit, and it means that the valine group kind of sticks out on the outside of the structure. And when that happens, valine kind of interacts with the other hemoglobin molecules around it, and it polymerizes. So it means that within the red blood cell, all the hemoglobin is in these long chains. And when all the hemoglobin inside the red blood cell is in these long chains, it means that the red blood cell changes its shape. And instead of being the nice kind of elliptical shape, it becomes this weird sickled shape, like in the picture. And yeah, because of that, it means that the membrane of the red blood cell gets really sticky because it's been kind of disfigured. I don't know what the word is, but it's like changed shape. It gets really sticky because it's damaged. And it also means that the cells aren't so good at kind of flowing past each other. So if you watch like these like YouTube videos of red blood cells flowing past each other, they're quite good at kind of changing shape and just flowing past each other. Whereas when it's sickled, they're not so good at doing that, and they tend to just kind of clump together. And the other problem is that the lifespan of the sickled red blood cell, because your body picks it up that it looks abnormal, the lifespan is massively reduced. So the cells actually only last for about 17 days. My other quick question was going to be, does anyone know how long a healthy red blood cell lasts for? Yeah, perfect. Loads of urine. Yeah, 120 days. So when it's reduced the lifespan down to 17 days, that's a massive difference. So they're the two main things that cause all the problems in sickle cell. So it's the hemolysis, because the cells look weird and your body's getting rid of them, and this vaso-occlusive phenomena where the cells are just sticking together in the vessels. So next question, does anyone know kind of what are the main conditions or environments that cause this sickling of the cells to occur? So there are 5 on my list. So hopefully you guys can get some of them. High altitude, yeah, that's related to one of them. So one of them is hypoxia. So yeah, hypoxia. Same thing though, high altitude's the same. Does anyone know any other ones? Yeah. Dehydration, yeah, perfect. So that's 2 out of my 5.
What, low temperature?
Yeah, when it's cold. Perfect. Yeah, it was doing really well. There are 2 now. Exertion. Yeah, related to when acidosis, perfect. Yeah. And there's one more and I've forgotten what it is now, so I'm gonna move on. What's the next one? Okay, I'll look. So infection, which is actually related to the other 2. So yeah, cold, hypoxia, dehydration, acidosis, which is due to the dissociation curve that Ash told you about earlier. So when you have more deoxygenated hemoglobin, it's going to polymerize more. And infection, which is kind of to do with the dehydration and maybe hypoxia and acidosis as well. So lots of different complications of sickle cell, and they're usually split into the acute complications and the chronic complications. So a really big one, there are loads on this list, but stroke is massively important. Loads of people with sickle cell have strokes. Then gallstones, so when you have hemolysis, it makes bilirubin, which then makes gallstones. What are the other ones? Osteomyelitis, so you have kind of clots in the bones and then it gets all infected because the blood supply is not so good. Acute chest syndrome, so a massive proportion of people with sickle cell have acute chest crises, and kind of all of the short term. So the acute complications are usually just where there's a clot, and then the chronic complications are kind of when you think about the long term effects of those clots. So if you have lots of little clots in the chest, then you're eventually going to get on to get pulmonary hypertension. If you have lots of little strokes, you're going to get neurocognitive dysfunction. So most of them kind of lead on from each other. The main one to talk about is, and another one of the lobs on your list is talking about the spleen. So in sickle cell, quite often you'll get lots of little infarcts in the spleen, and that really damages kind of the functions of the spleen. So to know what that causes, you need to know what the functions usually are. So there's a really helpful mnemonic that is FISH. So F stands for filtration of encapsulated organisms and blood cells. I is for immunological function, so in newborns it makes lymphocytes, one of the white blood cells. S is for storage of blood, so lots of your blood is stored in your spleen, which is why it's a problem. If you have a splenic rupture, you can lose loads of blood and it's really dangerous. And hematopoiesis in the fetus, so in fetuses a lot of your blood cells are actually made in the spleen. when you get older, it's more in the bone marrow. And the really important thing to know is that when your spleen isn't working and it's not filtering out all these encapsulated bacteria, the people with sickle cell get a lot more prone to infections. And you need to know a little bit about some infections that they're prone to. So there's a mnemonic to help you remember the different encapsulated organisms, and some killers have pretty nice evasive structured capsules. That stands for Salmonella, Klebsiella, Haemophilus influenza type B, Pseudomonas, Neisseria, E. coli, Streptococcus and Cryptococcus. So it's not really important that you remember all of them, but it's just good to have an idea of, I think one of your lobs is just name a few different encapsulated bacteria. So I think that's quite a good way of remembering them. So moving on to how you manage sickle cell. So patient education is really important. So they need to be made aware of different kind of circumstances that are going to make them more likely to have sickle crises. So things like avoiding being cold, being careful when they exercise, being very conscious if they get an infection, that their spleen doesn't work very well and won't be filtering it out. Then there's kind of general care, so they need folate supplements, they need to have immunizations because they're more susceptible to infections, and they do get put on antibiotic prophylaxis as well, just to help with the infections. In terms of the acute complications, analgesia is really important. So I don't know if you guys had it, but we had this week where we actually got to speak to lots of patients with sickle cell, and there's a lot of stigma around like drug-seeking behaviour in people with sickle cell that I think Georges are trying really hard to get rid of. And the message really is that if someone with sickle cell tells you they're in pain, then they probably are in a lot of pain. So listen to them, give them analgesia. Fluids is also really important because obviously if you're dehydrated, you're gonna more likely the cells are gonna stick together and you'll get more vaso-occlusive phenomena. And exchange transfusions you can also use, which is where they take out some of the sickled blood, so they take out some blood from the patient and then transfuse them with some healthy blood instead, and that just helps lower the concentration of the sickled hemoglobin. In terms of preventing these vaso-occlusions, you can give top-up transfusions where you just give a little bit of normal blood to help lower the concentration of HbS. You can do exchange transfusions, and there's also drugs like hydroxycarbamide or hydroxyurea, which I wouldn't worry about too much, but they're drugs that help to increase the percentage of fetal hemoglobin, and then that decreases the amount of sickled hemoglobin. And then in terms of the chronic complications, if they have regular transfusions, then you need to make sure they're on an iron chelator, because if you have too much iron going around in your blood, which you do get if you have regular transfusions, you need to try and manage the effects of that. And then there is now a curative treatment for sickle cell, which is hematopoietic stem cell transplants, but they are still very rare and still quite dangerous, so not done very often. And then the last little bit we need to talk about is thalassemia. So thalassemia is another one of the hemoglobinopathies, and it's where you have a severe reduction or an absent reduction of either the beta or the alpha globin chains. So beta thalassemia is when you don't make the beta chains, alpha thalassemia is where you don't make the alpha chains. And there's kind of different severities within both, depending on how many of the genes are mutated. And then beta thalassemia major is the one that you really need to know about in first year. So in beta thalassemia major, there's a problem with chromosome 11, and that means that they don't make any beta globin at all. And they have a kind of raised proportion of fetal hemoglobin and that other HbA2, which is this other form of hemoglobin with delta chains instead of the beta chains to compensate. And it presents in childhood with hepatosplenomegaly, a microcytic anemia, and faltering growth. And it's much more common in Indians, Mediterranean people, and people from the Middle East. And it's actually screened for during antenatal visits for everyone in the UK, mainly by asking about background, and then they can do genetic testing if they think someone's high risk. And beta thalassemia causes this chronic hemolytic anemia. So because the cells don't look normal, they're constantly being destroyed. And they also get this kind of extramedullary hematopoiesis. So they start making blood cells in places that you wouldn't normally make blood cells. So they get this frontal bossing, which is in the picture at the bottom, and maxillary overgrowth, where like literally their skull is trying to make blood. And they also have lots of problems with osteoporosis as well, because they're making blood in places that they shouldn't be. And in terms of the management of thalassemia, they are dependent on lifelong transfusions. And as I mentioned earlier, that can cause iron overload. And so they need to be on iron chelators lifelong as well. So that was everything I had to talk about for this week. I really like haematology, so I hope you guys do too. Other things to recap, so the oxygen dissociation curve, which Ash spoke about earlier, hematopoiesis, mainly just like where blood's made, and then just types of bacteria in a bit more detail as well. But that was everything I had to talk about. So if there are any questions, then let me know.
Questions? I'm just posting the feedback link in the chat as well. So please do fill in the feedback, and I've attached the slides to the feedback form. So as you go through, you'll see a link at the end.
Was this one for the feedback form?
I also sent, yeah. I put the QR code in all of the end.
Okay, I'll leave that one up.
But I think the link is a lot better if they're on their laptops anyway.
Cool.
Yeah. We'll hang around for a bit if you want to unmute and ask questions as well about anything, literally anything.
Yeah. Anything jet related.
Yeah.
Or other things.
Yeah.
Not jet related. Life related.
Okay.
I hope it was helpful though today. Oh,
yeah.
You're welcome.
And thanks guys for attending.
Yeah, thank you for coming. Oh, sorry about your connection.
Oh, we'll definitely have a recording, and I'll figure out how to get it up.